accepting the invitation.
Okay, thank you very much. It's a pleasure to be here, and thank you to all the delegates who've signed in on a Sunday. It's quite overwhelming actually to see how many people are online, and you're all from all corners of the world. So I think you've got every continent represented here in your webinar, Asma. So this is very wonderful to be part of it. So my talk is going to be a bit more of a general overview about NIPT in twins, and as Asma said, I'm going to cover the general recommendations from the International Society for Prenatal Diagnosis position statement on NIPT in twins from 2020. So I hope you can all hear me and see my slides, and apologies if you all heard my husband offering me ice cream earlier when I inadvertently unmuted myself. Sorry, Francesco. Here we go. I'd like to start by acknowledging that the country on which I'm living and working is the unceded lands of the Wurundjeri people of the Kulin Nation. It's traditional in Australia to acknowledge the traditional custodians of the land in which we're working and speaking. So that's where I am today, also known as Melbourne, Australia, and I don't have any financial conflicts to declare. So why are we talking about twins? Well, if we all of us working in maternal fetal medicine see a lot of twins. They're interesting, and they're also increasing. So since the 1980s, the global twinning rate has increased by a third, from 9.1 to 12 twin deliveries per 1,000 per year. And you can see from this map here that the rate of twinning varies quite considerably by country, and part of the reasons for the rising rate of multiple pregnancies is the rising maternal age, which increases the number of spontaneous dizygous twins that occur with increasing maternal age, but also the association of increased maternal age and infertility, and IVF obviously is a big contributing factor, particularly in high-income countries. And another reason why twins are increasing globally is that the regions that have high spontaneous rates of twinning, particularly in Africa, are also increasing their birth rate. So that's why it's becoming more of a relevant issue for us everywhere. This is a nice table from this paper showing the rate of twinning by continent. You can see that Africa has the highest rate of twinning per 1,000, followed closely by North America. But in terms of the overall share of twin deliveries in the world, Africa and Asia, because of their higher birth rate and bigger population, actually produce the bulk of twins, and North America only contributes to 4% of twins around the world. So that just puts all of this into a bit of global perspective, because we do have a very international audience here tonight or this morning. So as Francesco covered, NIPT really it's been with us for over 10 years now. It's really revolutionised the way we screen for aneuploidy. And this is data on singleton pregnancies from a recent systematic review commissioned by the American College of Medical Genetics and Genomics. And in this evidence-based, in this systematic review, they showed that the sensitivity for NIPT for trisomy 21 is almost 99%, and similarly high for trisomy 18, and also high for trisomy 13, but with less precision because trisomy 13 is much less common. The specificity is also very high, so very low false positive rates, which has brought great benefits everywhere for reducing unnecessary invasive testing for false positive screening results. So the American College of Medical Genetics and Genomics and ISPD both recommend aneuploidy screening with NIPT as a first-line test for the general population in singletons. But of course, we've been reasonably slow to come up with firm recommendations for twins, because the data has been much slower to accumulate because twins are much less common than singletons. In 2020, ISPD published a position statement on NIPT, or cell-free DNA screening for Down syndrome. Mark was one of the authors, and the first author, Glenn Palamaki, helped produce this very nice summary of different screening methods for twins and their sensitivity and specificity. So this graph here on the right is a receiver operating curve, where along the y-axis you have the false positive rate of the screening test, and on the y-axis you have the detection rate. And you can see in going from the lowest accuracy to the highest accuracy screening test, we have maternal age, which has very high false positive rates and not very good detection rate. The next screening test on the ladder, working from the bottom up, is second trimester serum screening. That has slightly better, a lower false positive rate than just going by age alone, but doesn't really improve the sensitivity too much. Nuchal translucency and maternal age will improve the detection rate, but we still have high false positive rates over 10%. And then once we get into first trimester serum screening tests, such as the first trimester combined test and the integrated test, we start to improve the false positive rate and have a consistently high detection rate around 80%. Nuchal translucency alone actually performs quite well for twins and for and certainly in many settings, it's still the preferred test for triplets, but cell-free DNA certainly wins over all of these other screening methods by having the highest sensitivity and specificity. So what makes twins interesting with NIPT? Well, I'm sure you all know that NIPT is based on the analysis of DNA in maternal plasma, and actually what we're detecting from the pregnancy is the placental DNA, not from the fetus itself. And of course, with twins, you may have one or two placentas, and that's what keeps things interesting. The fetal fraction is the proportion of cell-free DNA in the maternal plasma that arises from the placenta. And in singletons, the average fetal fraction is about 10% in late first trimester when NIPT is usually being performed. And the higher the fetal fraction, the more accurate and reliable the result of the NIPT is. So it's a very critical quality control measure in NIPT. So what happens when you have a second fetus? It doesn't double the amount of DNA, cell-free DNA you have, but it does increase it. And the research now shows that for dizygous twins, so these are by definition also dichorionic, the combined fetal fraction is 35% higher than singletons. So if you're kind of looking at the overall contribution of the pregnancy to the maternal plasma pool, it would be, rather than say 10%, it would be 13.5%. But the individual contribution from each fetus is about 35% lower than a singleton. So it means that each fetus in a dichorionic pregnancy is contributing a fetal fraction, say, of around 7%, so less than a singleton where you would expect it to be 10%. And because dizygous twins are usually discordant for aneuploidy, because they arise from two different eggs and two different sperms, you're really essentially trying to detect a single fetus that is aneuploid, but with a lower fetal fraction than a singleton. And that's what makes NIPT in twins technically much more challenging for the laboratory. And so their quality assurance processes do ideally involve testing fetal fraction and, if possible, fetal fraction from each twin. So what's the situation in monozygous or monochorionic twins, or monozygous twins? Actually, they can be dichorionic or monochorionic. Again, you will have a slightly higher combined fetal fraction. And from this paper published in Prenatal Diagnosis a few years ago, it showed that the combined fetal fraction was 26% higher in monozygous twins. And because these twins are usually concordant in their carrier type, then it's actually an advantage to have monozygous twins undergoing NIPT. So this is kind of what has been evolving in the evidence base over time. And so that's why when you are using NIPT for twins, it's really important that you write all the relevant clinical information on there for the laboratory in terms of what you know about zygosity, chorionicity, and if it was an IVF conception, how many embryos were transferred. Really does help with their interpretation. More recently, there was a systematic review that was commissioned by the American College of Medical Genetics and Genomics. I showed you some of the data on the singletons. They also did an analysis on NIPT in twins. And you can see that there are only 7 studies that they included, so many fewer than for singletons, but there was enough data to perform a meta-analysis. And you can see that the sensitivity of NIPT for trisomy 21 in twin pregnancies is now 98%, so approaching that of singletons with a similar specificity. This translates to a positive predictive value of over 90%. Trisomy 18 similarly has very good detection rate. That was estimated at 90% with a specificity of over 99.9%. And that translates to a positive predictive value of about 90%. And then for trisomy 13, the sensitivity was estimated at 80%. You can see there's a very wide confidence interval there, anywhere from 30 to 97%, just because it's such a much less common condition. Only 4 studies included in that analysis, but again, a very high specificity. So overall, there's very good evidence now that it can be used with confidence in twins. However, the whole issue with fetal fraction and the per twin fetal fraction does mean that the NIPT failure rate does appear to be higher in twins than in singletons. In the ISPD position statement, this was kind of estimated to have a mean of 3.6% failure rate, but it ranged from 1.6 to 13.2% based on the different studies. And the most common reason for NIPT failure in twins is insufficient fetal fraction. There are some other references there that you might wish to look at, which show that test failure rates in twins also vary by chorionicity, zygosity, and the type of NIPT platform that you're using. So it's quite a technical area. You probably don't need to know too much more than it can be higher than a singleton, and that's an important thing for pre-test counselling. And it's also worth asking your specific laboratory what their test failure rates are. Unfortunately, there's no common reference standard for measuring fetal fraction, or there's no definition of an acceptable fetal fraction in twins. So it really is a laboratory-specific threshold and internal quality control practice. So it really does depend on who you're working with and asking the right questions. So in the ISPD statement, they did do a review of all the different professional societies and what they were recommending for twins. Now, this is 2020 data, so some of this is now not too current, but you can see back in 2020 that the professional societies were all fairly cautious in their recommendations. Some of them didn't make any recommendations at all about twins, but since that 2020 publication from ISPD, the American College of Medical Genetics and Genomics, the American College of ONG, the Society for Maternal Fetal Medicine, ISPD, and our Australian and New Zealand College have all come out endorsing the use of NIPT in twins. So in summary, the evidence now shows that using NIPT for the common autosomal trisomies is appropriate in twins because there's now sufficient evidence to show that it performs almost as well as in singletons. There's a bit of discussion in the literature about the differences in the testing methodologies, but overall their screening performance appears comparable. So there isn't one that's overwhelmingly preferred over another, but they do have their individual the individual advantages and disadvantages. It is preferable for laboratories to be able to use the clinical information about zygosity for the interpretation of both the test results and calculating fetal fraction. So that's an important thing to provide your laboratory. And ISPD didn't comment on NIPT for conditions other than the common autosomal trisomies in twins, but the American College of Medical Genetics, in their most recent position statement, said that the data really wasn't sufficient to make any firm conclusions about using NIPT for microdeletions or rare autosomal trisomies or segmental aneuploidy. And there's very limited data on triplets and higher order multiple gestations, so there were no recommendations on those particular pregnancies. And of course, all the societies remind us that when you have an increased probability result on NIPT in twins, as with singletons, it should be followed by genetic counselling and an offer of diagnostic testing to confirm the results. So I'm sure none of that is too controversial or too unexpected. And I thought I'd just take a few minutes to talk about what happens after a positive NIPT result, because that creates more questions. So what is the risk of fetal loss after an amniocentesis or CVS in twins? Is it a riskier procedure? This meta-analysis published in the White Journal in 2020 gave us very reassuring data showing that the rate of fetal loss before 24 weeks or within 4 weeks after the procedure is actually similar to the background risk of loss in twins that don't undergo a procedure. And for those having an amniocentesis, the pooled rate of fetal loss was 2.4%, compared with exactly the same rate, 2.4%, in those twins that didn't have an amniocentesis. For those twins undergoing a CVS, the pooled rate of fetal loss was 2%, compared with 1.8% in those not undergoing CVS, and that was not statistically significant. So that's reassuring. We can counsel patients who have a increased chance NIPT result that having a diagnostic test is not a more risky procedure in twins compared to singletons. But should you put in 1 or 2 needles? It's possible to sample. Do we need to sample each twin separately? Should we do that with 1 needle, puncturing both sacs, or do 2 separate entries? Well, for dichorionic twins, if you're performing an amniocentesis, it is recommended to sample both amniotic sacs because they are dizygous. If you're going to sample them, you need to do that individually. The thing about NIPT is it doesn't tell you which fetus is the one that is affected. So if you don't have any ultrasound findings to really tell you which one is affected, well, in either case, you may have an affected fetus with or without ultrasound abnormalities. So you do have to sample both. If you're doing a CVS in a dichorionic twin pregnancy, it is recommended that you do 2 separate punctures, or you can do a single puncture technique, but you have to sample the 2 placenta in sequence. So you sample the furthest placenta, withdraw the needle, and then sample the second. So a very technically challenging procedure, but one that can be used in dichorionic twin pregnancies. With monochorionic twins, slightly simpler. You may, if there's concordant growth and anatomy on the twins, you may sample a single sac, and that's assuming that because they're monochorionic, they're also monozygous, so they would generally be concordant for their karyotype. However, in very rare situations, you can have a monozygous pregnancy that is discordant. And so if you have a monochorionic twin pregnancy that where one fetus has a structural abnormality or selective growth restriction, you actually do need to sample them separately. And that would be with an amniocentesis, with dual sampling with a 2 puncture technique. if you're performing a CVS, and that's only recommended if both twins look normal structurally and have concordant growth, then you can do a single sampling approach, and you're assuming then that they both have the same karyotype. So that's diagnostic testing. So why would you worry about monochorionic twin why would you worry that the twins wouldn't have the same karyotype? It's because there's this very unusual phenomenon called heterokaryotypic monochorionic twins. And this is a nice case report actually just from this year that shows you how complicated screening and diagnosis can be now. So these twins were discordant for hydrops. So twin A was hydropic. You can see where that asterisk is. There's a very thick nuchal translucency measurement there. And twin B looks normal. And they were confirmed to be monochorionic on an early ultrasound. So ideally that would be performed on ultrasound before 14 weeks gestation. The patient had SNP-based NIPT, so single nucleotide-based methods can actually also determine zygosity. So this NIPT assay confirmed that they were monozygous females with a low probability of aneuploidy. The team then decided to go on and do a CVS. And that showed a normal G-banded karyotype. They also performed a chromosome microarray, and it showed that the placenta was mosaic for a partial duplication on chromosome 13. And that was interpreted as a variant of unknown significance. So you can imagine that doesn't really help the pregnant woman very much to understand what's happening with her pregnancy. And they had to wait a few weeks and then proceeded to a dual amniocentesis with dual puncture of each sac. Twin A returned a result of monosomy X, and twin B had a normal karyotype of 46XX. So you can see this woman had, let's see, a total of 5 different types of genetic testing there. She had NIPT, she had CVS with a G-banded karyotype and a microarray, and then she had 2 amnios, and they all showed different results. And this is due to the fact that there was post-zygotic non-disjunction in the twin that was aneuploid, and there was also confined placental mosaicism for that 13q duplication. So things can get complicated very quickly with twins, so you do really rely on your genetics colleagues in the laboratory to help you with the interpretation. So what happens after you've perhaps made a diagnosis of twins that are discordant for aneuploidy? Of course, there are lots of different choices. Some women will choose to continue. Some women will choose to have a termination. And many women will ask about the option of having a selective termination where the baby or the fetus with the chromosome condition has its heart rate stopped with a procedure and allows the twin with a normal chromosome complement to continue through to full term. So this is a publication from this year from France. 24 participating centres contributed their data on outcomes after selective termination in fetuses that had an anomaly diagnosed before 20 weeks. So this is a range of anomalies, not just genetic, but also structural. And they looked at the outcomes for those that postponed the selective termination until the 3rd trimester, with those that had an immediate selective termination within 2 weeks of the diagnosis. And they found that an immediate selective reduction resulted in a lower preterm birth rate, but a slightly higher loss rate of the euploid twin. So if you defer selective reduction to the 3rd trimester, there's a very good perinatal survival rate, but you get a higher preterm birth rate. And that makes sense, I guess, if you're just looking at, the complication of the procedure. If you defer the procedure till later, then the risk of preterm ruptured membranes and preterm labour occurs in 3rd trimester, where survival is expected to be good. If you do the procedure before 24 weeks gestation, then if you have an adverse outcome like rupture of membranes or preterm labour, then your survival is going to be lower. But then conversely, you're going to have less preterm birth once you get to a gestation over 24 weeks. So that's these are the things to discuss with couples when they're considering their options after a diagnosis of a twin pregnancy that are discordant for a chromosome condition. So to summarise, NIPT's twins, NIPT in twins is now recommended as standard of care by several international societies now. There's enough data now to show that it performs better than traditional forms of screening in twins, but we have to remember that the no call or the test failure rate may be higher than in singletons. Because chorionicity and zygosity and other factors like IVF and the numbers of embryo transfers are relevant, do provide the laboratory with that relevant clinical information. And as we'll probably hear from some of the other speakers tonight, the interpretation of the results can be very complex. So you should call on your colleagues to help when you've got anything unusual going on with twins, because I guess two heads are usually better than one, and because these are usually quite uncommon situations, there's often not a lot of data to guide us in a lot of these areas. So thank you very much for your attention. Be very happy to take questions at the end. Thank you.
Okay, well, thank you so much, Lisa. A very comprehensive talk, covering various aspects of NIPT and the guidance and what happens next if you have a high risk result. So we're going to move on with our next speaker, who's